This is the Celiac Project, two guys talking gluten-free. Just wanted to give a little disclaimer. We are not medical experts, doctors, dietitians,
nurses,
bone experts, surgeons.
We're only experts at being celiac patients.
So enjoy the show. And if you're going to do any changes to your diet or need real medical advice, please go to the medical professionals.
That's what they're there for. We hope you're enjoying the special month of Celiac Awareness podcasts. We have an amazing treat for you. If you want to listen and watch this week's episode with Dr. Fasano, you can go to youtube.com/@celiacproject and watch it there.
If you prefer, you can listen as you usually do. We hope to have some of our future shows on video as they are available, so look for that as well. Also, a reminder that our special 400th show will be out May 29th, so be sure to check that out. Now let's get to the show.
Sounds good.
You found the Celiac Project Podcast, two guys talking gluten-free. I'm Mike.
And I'm Cam.
And who's joining us on the podcast today, Cam?
Today, we have one of the most renowned celiac doctors in our community, Dr. Fasano.
Yeah, we're so honored to have Dr. Alessio Fasano join us for show number 399. Let's get to it.
Sounds good.
Cam and I are so thrilled to have Dr. Alessio Fasano joining us today. How are you, Dr. Fasano?
I'm doing great, Michael. How are you?
Very good. We were just discussing before we came on. I always wanted to have you on a very special podcast. We're on episode 399, and it's Celiac Awareness Month right now as everyone is listening. So I thought this was a perfect time to have you on. As I say, we're thrilled to have you on. And it's been such a long time, Dr. Fasano. So good to see you today. The last time I spoke to you was 2013 at the International Celiac Symposium when the University of Chicago hosted it, and it was just over 10 years ago. Wanted to open, I was looking back, and Cam and I have been doing a lot of looking back lately, and 10 years seems like a good chunk of time to ask you, if you look back from when we were sitting down together in 2013, how do you feel overall that things have progressed for celiac disease research and treatment?
I think that in the world of celiac disease, 10 years are an eternity because we had an acceleration since that time. 2013 was the time in which celiac disease was still not in the radar screen in the United States, was considered to be an exceptionally rare condition in the United States. And that was the year that we published the epidemiologic data that plant the flag celiac on U.S. soil, the ones that show that 1 in 133 people has affected celiac disease, the vast majority not being diagnosed. That was the time in which the availability of gluten-free product was still sketchy and qualitatively not in the top of the game and very unaffordable for a vast majority of people because it's extremely expensive. And that was the time in which the research community was not really enthused to invest time to dig into celiac disease pathogenesis and therefore trying to find better way to handle the diagnosis and treatment of the disease. What happened these 10 years was unpredictable because I was telling you there was this huge acceleration. We know much more of the disease than we knew at that time. We know now that this is an autoimmune disease. We know that is a one-of-a-kind autoimmune disease because we know the trigger that is gluten. We know that the gluten-free diet is extremely effective in managing celiac disease, but not infallible. And that fueled a huge amount of interest by exploring the new knowledge and the pathogenesis of complementary alternative treatment to the gluten-free diet.
Very nice answer to that. And it is fascinating when I think back that there were no treatments, there were no pharmaceutical companies that were looking into it. So I do feel like we've come a long way in that regard.
Piggybacking off of that, I want to thank you again for joining us today. And it's funny, as celiac brain fart, how I've listened to you so many times on symposiums that I literally was like, wait, we've already had you on. And then I had to realize that this was the first time we're having you on because I'm so comfortable and it's just so normal to hear your voice. It's so interesting to finally get to have this lived experience. But piggybacking off of what Michael was saying with how the progress has gone, what do you think the awareness is like? We do an annual celiac State of the Union where we kind of reassess what the annual changes have been for us in the community. What would your take be on from a patient standpoint, and then also how people outside of our community's awareness of celiac disease is?
Yeah, again, thank you, first of all, Cam, for the nice words. 13 years ago, the top priority was awareness, increase the awareness, but not in general public, among healthcare professionals, that they did not have this in the radar screen. I think that, again, initiatives like yours that put this on the map and many others that work toward that goal really make a huge difference. I don't think the awareness is an issue anymore. Remembrance of that this is still an issue, a respect for a condition that was brushed off as something that was rare, and by the way, for which we had a treatment, so there was no need for research, has changed completely what is the current landscape. And this thanks to the appreciation of the complexity of the condition, but also because this is a one-of-a-kind model of autoimmunity, and therefore experts in other fields, immunity, infectious diseases, people that are interested in metabolomics and so on and so forth, they start to really dig into working on celiac disease as a model to recapitulate stuff that you can't for other conditions like multiple sclerosis, type 1 diabetes, because there are so many unknown they don't control that you can with celiac disease. So I would say that the tasks that we were really facing 10 years ago, the most successful was just the awareness. And having May as the celiac disease month, that was something that we embraced at the very beginning when we set up the first Center for Celiac Research and Treatment in the United States. When we proposed May as the month, seeing that this legacy is still ongoing, it's very refreshing.
Yeah, it's nice to have a month, and we try to lean into that month to take a look back and also see where we're going and how we can improve things. It's really interesting going back again. Something that struck me when we talked and I interviewed you for the Celiac Project documentary was that you brought this up a little bit just today, knowing that gluten is the trigger for celiac has been so helpful, and it'll be helpful in treating other autoimmune conditions in that it's the one that we have the trigger. You also talked to me, it was really fascinating. You were talking about how you envisioned that healthcare and treatment of patients was going to become a lot more personalized. And again, it's fun looking back at that. Can you explain your thoughts on that, and maybe how you see that coming into fruition a little, and where you see the future for that?
Now, personalized medicine is a fashionable concept, but when you and I discussed about that, was very visionary, let's put this way, because nobody really conceptualized even the possibility that celiac disease needs to have personalized approach. That this is a condition for which you have a problem with gluten. Everybody goes gluten-free, everybody should be taken care of. So there is no much of personalization there. There are some interesting epidemiological data since our first reports that seems to suggest that celiac disease is a final destination. How you got there is very different from one individual to another. And therefore, if we really want to be serious about tackling complementary alternative treatment beside the gluten-free diet, we really need to dig into those personalized paths that people they take to get this final destination. What are the peculiarities, the unicity of celiac disease, and why we learn this lesson big time from celiac disease? The peculiarities is that all autoimmune disease, there is a genetic component, but peculiarity number one, some of these genes, particularly this HLA, there's a unique penetrance. Almost everybody with celiac disease will have this HLA-DQ2 and or DQ8. The other peculiarity that we discuss more and more, you and Cam both alluded to, is the only autoimmune disease for which we know the trigger. Meaning that, again, we have a solution for a treatment, not a cure, but a treatment that we don't have luxury with other autoimmune diseases for which we don't know the trigger. We have a biomarker of the autoimmune process that is antibodies against tissue transglutaminase. Oh, and therefore, you can do non-invasive screening to see who was really at risk of celiac disease. All this led to some epidemiological data that were quite remarkable. Remember that when we had the discussion 10 years ago, the concept was that celiac disease was a pediatric condition. And if you were an adult with celiac disease, it means that you start that condition when you're a baby, because gene and environment, HLA and gluten, were considered to be necessary, sufficient to develop the problem. And therefore, when the two encounter each other, meaning when baby food was introduced, that's what we thought that the march for celiac disease would start. Little we knew that when additional epidemiological data from us and many others show that you can develop the disease at any age. So in other words, you can be born with the genes of celiac disease, you can eat gluten, but you don't immediately start that march. And some people, they do, but some other people, they start the march in their 50 or 60, meaning there are other elements at play that eventually will, one, dictate when this genetic predisposition will become clinical actuality. And two, that if we have an understanding where are this mechanism, now you can personalize intervention to try to understand, can we treat better this situation by eventually intercept complications, ongoing symptoms, and so on and so forth in people that still have it, or even ambitiously to prevent the disease. So that's where now the field is all about, to try to get this wealth of information and trying to really personalize this approach to manage celiac disease.
And I know you're saying that's the more visionary approach, but we do have way more drugs that are in the pipeline now at various stages than ever before. Do you have any feelings on the ones and that are becoming available, or not becoming available, but are getting closer to becoming something that would become available? And do you feel that one's more promising than another or anything like that?
Since 2005, when the first time was conceptualized, at least in writing, theoretically, of a possibility of a drug for celiac disease, there have been hundreds and hundreds of clinical trials. Right now, they exploit the steps that we acknowledge, that we know that can lead to break intolerance at the onset of celiac disease. Some are more advanced than others, as you were saying, Cam. The two most advanced is one, we know that gluten, that is a mixture protein, by the way, cannot be completely digested by humankind because we don't have the digestive enzyme to completely digest them, but bacteria, they do. So the use of these bacteria-derived enzymes to completely dismantle gluten so that will not be visible to the immune system and therefore trigger the inflammatory process of celiac disease is one approach that is coming along and is moving really forward. The other one is to prevent this trafficking gluten from the lumen into your body to fortify the barrier of the gut that seems to be not working 100% in people with celiac disease. And that's another approach. These are the two ones that are more further along. As you probably know, clinical trials are divided in stages. Mm-hmm. So for phase 1 all the way to phase 3, these two that I mentioned are the ones that are close to phase 3. Mm-hmm. So meaning that if they will pin out to be correct, the next is commercialization. So we have this in the market. So that's where we stand right now.
Got it. Thank you. Appreciate that answer.
Yeah, that's very helpful. And hopefully we'll have something soon that will be helpful outside of the gluten-free diet alone.
Can I add one more thing too, real quick? I don't mean to cut you off, Michael, but because you and I have both been in drug trials ourselves, I just was wondering, Dr. Fasano, if you had any words to people that have not participated in drug trials, because I know that these are all facilitated based off of us as patients to participate in them.
Yeah, I'm glad that Cam, you made the point. Again, it takes a village to really move a field forward, like finding a better way to handle celiac disease. And village means dedicated scientists, people that are focused and dedicated their career to understand better condition, in this case, celiac disease. Clinicians that care for patients with celiac disease and take this seriously. But you can push the envelope only up to a certain point if we don't work as a community to really exploit this potential approaches of complementary alternative to gluten-free diet if the celiac community, meaning the patients, are not on board on this. There is not a way around. First and foremost, because unfortunately we don't have an animal model for celiac disease. But even if we do, at some point, you got to go to the next step, i.e. to try this in humans. And again, I think that if we really want to work as a team toward improving the quality of life of people that live this experience day in and day out, there is no other way to say, you know what, I do my part. And this may entitle that I have to sacrifice in some shape or form in terms of time, commitment, possible exposure to, of course, symptoms or side effects on a new drug and so on and so forth. But ultimately, since the beginning of the days, this is the way that progress in science has been made. And if we have a formidable drug now for IBD, for cancer, for HIV, that was due to a group of individuals that really stepped up to the task as a patient said, I do my part.
Yeah, it's a nice thing. Cam said we've both been part of a drug study, and there is that good feeling. Like you said, it's very important that we're a community, and it's a great way to help your community. And I did have that feeling like I was a pioneer. I was trying to forward something. I didn't expect to feel that, but I felt that. And I think you did too as well, Cam. But it's a good thing. Yeah. Wanted to ask you, hopefully we do have some other treatment soon besides the gluten-free diet that's helpful, at least in helping with cross contact or something like that. But wanted to ask you, when a patient comes to you, Dr. Fasano, and they're struggling and you've assessed that they're on the gluten-free diet, I know we all define that different ways. What are some of the ways that you might help them? Because I know we have a lot of listeners who are struggling. There's a lot of comorbid conditions. It's often hard to tease out what some of the symptoms that you're having are. And I know you're really helpful and get in there with your patients to try to assess their health overall. So if someone comes to you and they're still struggling with their health on a gluten-free diet, what are maybe some of the ways you could share with our audience that you help them through that process?
First of all, starting one step remote from what you said, once a patient is newly diagnosed with celiac disease, there are people that they brush this off, saying it's not a big deal. It's a diet. You don't have to take drugs. So it's all good. Read it on the internet and go your way. And that's the end of it. I believe that this is such a disgraceful way to really support somebody that's newly diagnosed with a chronic condition that he or she will have to live with for the rest of his or her life. So I think that first of all, it needs to be validated that this is not a walk in the park, that it's an investment that involves the entire family. And the hope is that, again, there's going to be a return on investment by improving the symptoms and feel better once you embrace the gluten-free diet. Of course, when this kind of statement is not followed by fact, so you've done all your efforts that you have been really investing, and you're not voluntarily being exposed to gluten, and yet your symptoms are still there, the frustration only increases exponentially. So that is the time in which a team effort, in which, not only the physician, but of course, another key figure is the dietitian, the nurse practitioner of the group, the psychologist, and so on and so forth, needs to step in and make the patients to be not alone in this journey, but supported by a team said, I'm with you. I know what's going on. This is not the first time they've seen it. And we will work this out because we will not leave anybody behind. And that's typically what we do. Again, it needs to be personalized because for some people is the inadvertent cross-contamination because, I don't know, some of the family members has not been aware what's going on. Some others because for professions needs to be on the road most of the time and be exposed to cross-contamination when dining out and so on and so forth. But anyhow, whatever that will be, it is always our approach to mention, let's work this together. And if we will find the source, so to be, if we do not, we have a plan B and then eventually a plan C to try to mitigate your symptoms or the continuation of the issues that you're facing as a bridge until one of these drugs will hit the market.
Can I add to or ask, when you say mitigate the symptoms, what about those instances where someone isn't getting symptoms, but they're still doing damage? Or is it, since we just don't really have the best way to keep track of damage, that's the best we can do for now?
Yeah, that's the other issue. Some people, they don't have symptoms, but ongoing inflammation. And, the question is, why should I bother? Why should I still be on the task and try to take care of the inflammation if I don't have symptoms? The obvious answer is that you're not doing any treatment. You're doing prevention of comorbidities that can be a big deal, a problem. If I don't have a flu, why should I take the flu vaccine? Because you don't want to deal with the flu or hepatitis and so on and so forth. It's in a matter of prevention. And again, the question is, how can we monitor this if we don't have symptoms? There are some biomarkers, of course, that we use. The autoantibody for celiac disease is one of them, but also nutritional parameters and so on and so forth, as well as sometimes we repeat an endoscopy to see if there's an ongoing inflammation. And if that's the case, we definitely need to take control of the inflammation, because by definition, if inflammation that is ongoing is not a good thing. Sooner or later will translate in a clinical outcome that can be not fixable anymore. For example, my thyroid can give in and I'll develop Hashimoto. At that point, can't do anything because it's gone, or even worse, type 1 diabetes, that kind of stuff.
I understand.
We've been talking a lot about studies. We had your colleague, Dr. Maureen Leonard, on a while back when you were starting the CD-GEM study. Could I quickly, I know we don't have to get too deep into it, but maybe you could tell people a little bit about that and any main takeaways that, you've gotten so far from that?
Sure. As I was mentioned before, when we're talking about personalized medicine, one of the unanswered questions is, what else is at play other than the genetics and gluten? Why some people are able to maintain tolerance to gluten and others, they lose this capability and they develop celiac disease at any age? Because, understanding that, it's the only grail to understand how can I prevent an autoimmune disease. Through the CD-GEM, there is a study in which we've been doing for the past decade, following neonates at risk of celiac disease. So somebody in the family has to have it. So they have a higher chance than the general population to develop disease. We really had the ambition to march with these kids and revisit the natural history of why somebody on a genetic predisposition will eventually take the wrong turn and develop disease and some will do not. So what we learn from this study? Lesson number one, genes are important. The gluten as the environmental trigger is important. They are necessary, but not sufficient. There are at least another three elements at play. One is these two worlds are normally segregated by a barrier, one of which being the intestinal barrier that is the largest that we have in our body, so that the two worlds can interact. So that if you lose that compartmentalization, gluten can get access in our body and create a problem. A fourth element is the immune system is hyperbelligerent, that continue to fight even if it's not needed. And five, and probably most importantly, this ecosystem, the gut, what we call the microbiome, it seems to be extremely important, if not instrumental, to dictate our clinical destiny. What we learn from the CD-GEM is that changes in the composition and function of the microbiome can change the function of our genes, put them in motion, so to speak, so to start the march from genetic predisposition to clinical outcome. So what we have seen, and we published this recently, is first of all, there is a quote-unquote microbiome signature that we can see months and months before the onset of disease that predict to a greater level of confidence, a very high level of confidence, who down the road will develop celiac disease. And this signature is characterized by the loss of protective elements of the microbiome, the ones that they fight against inflammation, and enrichment of those that, on the other hand, they favor inflammation. The other thing that we learn is that these protective elements, what they do they reprogram the intestine of the host that will stay put and would not react to gluten as an enemy. When you expose gluten in the gut of somebody with celiac disease, three things happen. One, that barrier function is not working anymore, so the intestine leaks. Two, there is an acceleration of the damage of the cells. So in other words, the cells are killed much faster because they see a sort of poison, so to speak. And three, the gut starts to react the exposure to gluten as fighting an enemy like a microorganism and produce mediators of inflammation, what we call cytokines. If you re-put into the equation these protective elements, these bacteria that are probiotics, they are lost by those that develop celiac disease. The immune system and the gut react differently, are reprogrammed to quote unquote tolerate gluten. So in other words, the instruction is, if you see gluten, do not increase your permeability. Do not become leak. If you see gluten, don't accelerate the killing of the cells. And if you see gluten, do not produce these chemicals that mediate inflammation. And that's how we maintain tolerance. And that's the only way to explain the inexplicable. How come that I can eat gluten for so many years and having problem, and then at my 60s, I develop celiac disease? Now, it's explained that if I lose those protective elements, I start the march at any age because I don't have that programming that defends me against gluten anymore. This is a very complex concept that is called epigenetics that has been described in celiac disease for the first time in an autoimmune disease using the CDGEM study, so that these protective elements are there to really instruct the mucosa of the gut. If you see gluten, treat it as a friend. And if you lose that friend, it will become an enemy.
And when you're talking about the permeability, is that just within the microbiome, or is it within the lining, or both? And are they separate, or how do those two interact? And is there any connection with that?
That's right. So the lining of the intestine is covered by a single layer of cells that in the past we thought they were cemented with each other. So that everything that from the environment has to come in our body, let's say gluten, has to go through the cell. Now we know that it's not the case. In between cells, there are doors, most of the time closed. They are called tight junctions. But when they are loosened up, they make a shortcut for large molecules like gluten to come through. So what gluten does, instruct the intestine to loosen up these doors so that it can find a shortcut for itself to come in, believe it or not. Why this is happening? Mainly because of two reasons. Why gluten per se can do this instruction, but also the change of the ecosystem, the microbiome. So that's the reason why the two are linked. It's what we call dysbiosis, can create the condition to make the intestine become leakier. And we know who is the mediator. There is this molecule that we discovered almost 20 years ago that is called Zonulin that increased gut permeability. And a matter of fact, in the CDGEM, soon after that, you see this quote-unquote signature of microbiome changing. A few months later, you see the zonulin rising from the baseline only in those kids that will eventually develop celiac disease and not the ones that will not. Meaning that, the steps are first dysbiosis, so imbalance, reprogramming of the gut to do that kind of stuff that I was telling you before, followed by an increased permeability that allow gluten to come in. And that is the beginning of the end. So in other words, when you break tolerance, and now that's a point of no return, that you will develop the problem.
I understand that. I really appreciate that explanation.
That is really fascinating. Thank you for breaking that down. Really a lot to chew on there. And Dr. Fasano, I'm seeing the time and we could talk to you for forever, really. You're just a wealth of information. Before we go today, is there anything that we haven't hit on that you think would be good for our listeners to hear today?
I think that, again, first of all, the future of celiac disease is bright, mainly because the knowledge has been increasing. We have a next generation of clinicians and investigators. They're very committed. You mentioned Dr. Leonard. This is one example of many worldwide that decided to really focused their attention on celiac disease. Many years ago, only aficionados of the celiac disease world were engaged there. Now we have a large group of young clinician investigators that would make the quality of life for people with celiac disease much, much better. I believe that, again, as we discussed also with Cam, we're almost at the finish line to see something else out of the gluten-free diet coming aboard, and process will be only accelerated if the community will continue to stay engaged and help with this clinical trial. There are efforts already in place in pediatrics and probably coming in adults short after to make a diagnosis in non-invasive ways by sparing the endoscopy. And again, I believe that now celiac disease earns the respect of a condition that should not be brushed off, because healthcare professionals are knowledgeable about it. The awareness is there. And I believe that, again, I see again a much brighter future, but please stay engaged.
Well said. Yes, we all have to do our part to raise awareness, get involved any way you can. And Dr. Alessio Fasano, such an incredible honor to have you on the podcast today. Thank you so much.
It's been my pleasure. Thank you for having me.
Thank you so much.
Thanks for listening to today's show. If you like the podcast, please consider leaving us a 5-star review on Spotify, iTunes, or wherever you listen to the podcast. This will help other people find the show. Thanks so much, and we'll see you next time.
See ya.